Thank you. So I'm Daphna Laifenfeld from Ibex Medical Analytics, and what I'm going to tell you about today is about the first ever deployment of an AI-based system in a pathology institute. And I'll tell you about the impact of that deployment and then a little bit about sort of what the future entails with that. But I'm really going to start with Dr. House here, who says, better a murder than a misdiagnosis, which, is probably a bit of an extreme view, but I want to put that in the context of pathology for a second. And there are definitely cases of misdiagnosis in different tissues, spanning different geographies. Sometimes it's false positives, sometimes it's false negatives. So let's put that in the context of the landscape, right? We talked about value-based medicine. There's a lot of cost that's involved here, right? So over 1.5 million cancer cases diagnosed annually. This is, by the way, US data alone. Almost 150 billion expenditures on cancer care alone. And pathology is a big part of all this story. So 68 million annual biopsies. This is only in non-hospital settings, so you probably want to double that for overall US numbers, and 16 billion of costs. So those errors that I just showed you have huge implications for the healthcare system. And that's not even talking, obviously, about the devastating effect for the individual. But assuming I convinced you that pathology or diagnostic errors happen, and that they're important both for the individual and for the healthcare, let's take a step back and just talk about sort of the evolution of pathology. And already, actually, the thought of or the concept of using a microscope to diagnose disease started as early as the 1600s. In the 1900s, the advancement or the progress was that you could take a picture of whatever it is that you saw under a microscope. In the 1980s, telepathology. So now you can have low throughput scanners and you can send an image so that you can discuss the findings with another pathologist. And in the 2000s, we have digital pathology, which really means scaling up. So now, theoretically speaking, we can scan all of our slides. We can stop looking through a microscope and look at the computer screen. But what's really much more interesting is here, which is what is noted here as the future, and kind of an AI type of graphic. And I'm just going to make the point that really that's the immediate future. It's really almost now, and it's really the only interesting advancement, I would say, or the second interesting advancement in pathology. The first one would have been actually molecular diagnostics, which isn't even here. So what are we doing in that context? So I told you about diagnostic errors. Pathology is very labor intensive, right? So basically, first of all, you take a biopsy, it goes through all kinds of processing, tissue is mounted on a slide, pathologist looks at that slide over and over, similar slides over and over again. Very labor intensive, takes a lot of time, a lot of effort. And there's a shortage of pathologists, a worldwide huge shortage of pathologists, and at the same time, cancer incidence is rising. So that gap is only getting bigger. So it won't surprise you that what we're trying to do, and what we're actually doing, is developing AI-based products that can support that work of the pathologist. And I actually liked in the first talk that I'm not familiar with the term, the extenders, I think you called it. And I would venture that AI, in some ways, at least right now, is a little bit like the extenders for physicians, and in this case, for a pathologist. So how do we do this? Well, we're talking about AI, so we start with data. We have a strategic collaboration with Maccabi, and I haven't been through all the talks here, but I bet you heard about the Maccabi database at least once. But I'm actually going to focus not on the clinical database, which is interesting also, and I'll come back to it, but on the interesting organizational structure that Maccabi has, which is very unique, and that is that they have a centralized pathology lab. That's very rare. So most HMOs and hospital systems will have several pathology labs that are dispersed geographically. In the case of Maccabi, they treat over 2 million patients, and essentially all of their histopathology, or generally biopsies, will go to a single lab in Rehovot. So what that means is that not only do we have access, exclusive access, to a huge database, but that database is harmonized, which is a really nice treasure trove, and of course we have the associated reports with it as well. So what do we do with that data? Well, the first thing that we tackled is prostate cancer. And the reason that we tackled that is some of these numbers here. So basically, PSA is the test that you do for screening for prostate cancer. There's 30 million PSA tests, again, US numbers, which lead ultimately to over 800,000 biopsies annually. But each prostate biopsy or each prostate case actually ends up having between 10 to 20 slides. So basically an order of magnitude higher than what you have here. And out of those, about 70 to 80% end up being benign. So again, go back to imagining the pathologist looking through a microscope, looking for each case at tens of slides. It's a huge amount of material, and at the end, the majority end up being benign. So it's not really surprising that you have up to 9% misdiagnosis, and I would venture that that number is probably higher. It's very hard to get real numbers in terms of misdiagnosis. So we're really trying to help here, and specifically in prostate, our approach in general, but this is, the data here is specific for prostate, is that in teaching or in training the algorithm is just like a pathologist in training. We don't believe that we can teach the algorithm just to identify cancer and no cancer, just throw at him a huge amount of data and say, you know, just learn based on these very superficial tags. Because what will happen there are two things. First of all, the algorithm will not be accurate enough because it will eventually run into characteristics, features, structures that are not cancer, but to him look too much like cancer. For example, atrophy, which even pathologists sometimes mistake for cancer. The other thing that will happen is it won't really help the pathologist enough, because when a pathologist does their diagnosis, they're not just diagnosing cancer. The report does not only include whether there is cancer or not, or the grade of the cancer, but it actually includes additional features. So we want to actually be a useful clinical tool. This takes a huge amount of work. It requires huge annotations, and so we've ended up building a huge annotation database in the process. And then there's the whole algorithmic framework, which I won't go into in detail, but the point being that this whole concept of AI and deep learning is at the center, but even before that, you start having to do things like just teach the algorithm to differentiate between tissue and non-tissue, because there are markings on the slides, and how will they know that that's not tissue? Or the different staining. That's a big deal, which I'll come back to in the next slide. So remember I told you that Maccabi has a harmonized database because it's a single lab. Well, the staining between different pathology labs is hugely variable. So you have to develop an algorithm that's significantly robust, that it can overcome that. And that algorithm that we built, so we've tested it on 3 different independent institutes. You can see that it has very high performance characteristics, so the AUCs very high, 0.97 and then 0.99 in 2 other institutes. This is where I go back to my point about the staining. So what's really interesting is we trained on Maccabi data set. This is an independent, obviously, Maccabi data set, but one would expect that you would do the best in testing on the institutes where you trained, and actually we see the reverse, and the reason for that is that the staining in Maccabi was very faint. And actually, when they saw these results, they ended up changing their staining as well. So it actually helped the pathologist even in that respect. But what's most interesting is that after developing the algorithm, after seeing the results, we asked these 3 institutes to supply us with benign slides from a consecutive time period, just so that the algorithm would run on them and see if we can identify anything that's strange there. And you can see here that with actually a relatively small number of cases, we identified errors or missed cancers in each one of these institutes. And when Maccabi saw this, and they saw that out of 80 consecutive benign cases, they actually had missed 2, they looked back at their medical records and were actually able to see that these 2, because remember, this is retrospective data. So these 2 patients here that the algorithm identified as cancerous, but the pathologist said were benign, subsequently had undergone another biopsy where they found high-grade cancer, higher grade than was initially identified by the algorithm, and had to have undergone prostatectomy. So the pathologist in Maccabi saw this and immediately said, I want to deploy this in Maccabi, because pathologists feel, they know they make mistakes and it makes them extremely nervous. It's a huge responsibility. And so what we did was we deployed in Maccabi, so now every prostate biopsy within Maccabi undergoes our algorithmic assessment. And the way that it works is what we call a second read. So essentially the slides get into the institute, they're scanned and they're uploaded into our system. In parallel, the pathologist does their review and analysis and comes up with a diagnosis, feeds the diagnosis into our system, and then there's a comparison. And if the algorithm agrees with the diagnosis of the pathologist, nothing really happens, but there's a confirmation. So now you essentially have 2 independent assessments for each biopsy. But in the case where the algorithm doesn't agree, then it raises an alert, and that goes back to a second pathologist that then can review and see if they agree or not with the algorithm. So basically, who's right here? So it's a safety net. That's why we call it a second read. Does not bias the way that the pathologist works, but provides them with the understanding that there's something else that's checking them so that they can feel more comfortable. Now, I told you that I would tell you about the immediate impact, and this is the immediate impact. So what you're seeing here is one bit of a slide from a prostate biopsy. This is hugely enlarged. So this, again, is a small piece out of 4 pieces in a single slide out of 12 slides, just to give you a sense of how much work the pathologist has to do as they review a biopsy. And the pathologist reviewed it and provided a diagnosis of benign, but the algorithm alerted, pointed to this specific region of interest with a heat map and said, look again. Now again, this is a very, very small piece. The pathologist looked again and agreed with the algorithm and ended up changing the diagnosis. Luckily, this was before anything reached the patient, so as far as the patient is concerned, there was no difference. But for us and for Maccabi, this is huge impact, right? So this is actually, if you stop for a second to think about it, it's the first time that AI actually diagnoses cancer. It's often used in different tools, but in this case, it actually diagnosed the disease and saved this patient from potentially being another headline as the ones I showed you initially. So we're not a prostate company. Prostate is our first product, and we're really developing in 2 axes. One is additional tissues, obviously. The intent is to support the lab in as many tissues as possible so that it's really meaningful also from a value-based perspective, but also from an application perspective. We find that second read, what I just described, is a great way to get into labs for various reasons, partially because it's very comfortable and convenient for the pathologist to interact with an algorithm this way. Very non-threatening, but the value starts being higher as you go into concurrent read, which is basically supporting the pathologist as they're doing their work, and they really ask for that already in Maccabi. So they're playing with this, it comes as a second read, they're like, but can we use it when we're doing the diagnosis? Can we click here and see what it says? And right now we're not doing that, but in the near future. And then first read, so just, again, extenders. For 50% of the benign cases, we can with 100% confidence have the algorithm say that it's benign. Take those 50% off the plate for the pathologist, have the pathologist actually deal with the important stuff. It's a win for everyone. And then ultimately, and I'll finish with this in the next slide, what we call next-gen diagnostics. So everything I told you about right now is essentially mimicking the work that a pathologist does. But in the future, the very near future actually, what we want to start doing is looking beyond the human eye. So essentially there is data, and these are publications that support this, there's data inherently in the morphology, in those slides, in those histopathology slides, that isn't being captured because humans do not have the capability to capture very small associations or to quantify them in a meaningful way. But this is really where AI comes into play, and where the combination of the pathology lab from Maccabi, but the medical records as well, helps us to try to identify associations between this morphology and the prognosis of the disease or even response to drug. Thank you.